Okay, 20 seconds. And I'll make sure I got audio there. Yep, you're good.
I got a feeling that doesn't work. Nope, there it went. I need to be
We got 8 seconds if you want to burp some more.
I did. I wonder if you get.
Here you go. In 3, 2.
Hello, everyone. We're ready for another student webinar. We're on number 42. And today we're going to be talking about the difference between an EGD and an endoscopic procedure. But the real reason we're going to look at this procedure is because we need to understand how to code intent when you have intent in a procedure. This is a question that came into our CCO club. It was so good that I thought, you know what, this is something everybody struggles with, both as a student and when you get out there and you start coding, because I don't think it's necessarily we get confused. It's just that as you're going along and you're reading all the procedures and think, okay, wait a minute, they were going to do this, but this happened and they did this versus this. And sometimes it gets kind of convoluted. So we are going to go through the question that came in, and it was a perfect example. So coding for intent, and the way we're going to demonstrate this is an endoscopy or an EGD. So let's talk about first, what's an endoscopy? An endoscopic procedure is just them going in and looking around. For the most part, they can look at any part of the digestive tract to do an endoscopy. Several reasons why they would do an endoscopy, but that is the name of the procedure itself. They're just going to go in and look at the digestive tract, okay? And your digestive tract is very, very long. They can do an upper GI and they can do a lower GI. Endoscopy, again, going in and looking visually with an instrument, which is called an endoscope. Okay, now going forward with an endoscopy, know that, kind of think of it as the same as a laparotomy, okay, where you go in and you're just looking around, okay? But this is a non-surgical procedure, whereas a laparotomy would be a surgical procedure because you're actually cutting into the body, whereas with an endoscopy, we're going through an orifice that was already created, okay, usually through the mouth, if we're going to do an upper GI. Now, when you see the term EGD, that is specific. That is an endoscopic procedure, but it's a very, it's a decisive procedure. It means they know what they're going to go look at. Okay, so if you say, hey, I'm going to go in and have an endoscopic procedure. Oh, okay. Well, what type are you going to have? I'm going to have an EGD. Okay, so that stands for esophageal gastric duodenal oscopy. Okay, and if we break that word down, esopha is your esophagus, gastro is the stomach, and duodenum, the duoden is the duodenum. Okay, and that's the opening that is at the small intestine as it's going up through from the small intestine in the stomach, that division there. There's a little sphincter there, but that's a part of the stomach where a lot of times they'll have ulcers. It's the pyloric sphincter goes into the duodenum. And again, it's very specific. What are they going to look at via the endoscope? They're going to look at the esophagus, the stomach, and the duodenum. Okay, and so I guess if you want to relate that to some other examples, that's like saying an endoscopy would be saying, hey, let's go get some ice cream. An EGD is saying, let's go get some Rocky Road ice cream or some Rocky Road. It's very specific. Well, you still know it's ice cream, right? But it's not just ice cream, it's more specific. We're going to get a specific type. We're going to go in and we're going to look at the esophagus, the stomach, and to the duodenum. Now, the procedure itself that this person gave us was an excellent procedure. So let's break this down. The procedure that was going to be done was an EGD diagnostic. So we know they are going to go do an endoscope, and they are going to look at the esophagus, the stomach, and the duodenum. And why are they going and look? It's to diagnose a problem. Okay, so again, being diagnostic is very specific as well. So why did they go in? Why do they want to see what's going on? Because the patient has dysphagia and a variceal screening. Now, a variceal screening is like having looking to see if there's varicose veins in the stomach. Ultimately, when you break that down. Okay, then the post-op, they stated solid food in the stomach. Now, usually when you see a post-op, it is a duplicate of what the pre-op diagnosis was. Okay, so you see a pre-op diagnosis and then you see a post-op diagnosis. And usually it would say like dysphagia and variceal, and where varices, where it was located at in the stomach or something. But this time, notice that it says post-op and it doesn't say diagnosis. Usually it does. And it says solid food in the stomach. That is an indication right there. That's a red flag that something went wrong. Now, if there is food, or if you're doing a lower GI, if there's anything that is there to where they can't get a good view for any reason, then they'll stop the procedure a lot of times. But that doesn't, it's not always the case, but they'll maybe want to go in and do it again. Maybe they didn't get a good prep. I know that my number 3 daughter, she has IBS really bad. And when she was little, they had her do the, she had a lower GI, and she went through the whole, that's when they give you that great big jug of Golite. She went through all of that. And yet when they went in to scope her, there was still fecal matter in there. And so they just stopped, and they said, we'll make her go through another prep. And she ended up going through another prep and another half a prep. So 2.5 preps just to get her intestines cleaned out. And but that was another whole diagnosis. So again, they went in, they tried to do the procedure, then they realized no, they couldn't. So they gave her another prep, and then they gave her an X-ray to try to see if it was, if they'd gotten everything, and they hadn't. So they made her take more prep, and then finally they were able to see what they needed to. So again, there's reasons why you would stop a procedure, that being one of them. You can't treat what you can't see. So they are just giving the details that for the procedure, and I'll just go ahead and read this. Normally we just skim through them, but it's very short. So the endoscope was inserted into the mouth and advanced under direct visualization to the stomach, because there's a camera on this device. A careful inspection was made as the gastroscope was withdrawn, including a retroflexed view of the proximal stomach, cardia, and fundus, which I've got a graphic, and I'll show you where all of that is in a little bit. Appropriate photo documentation was obtained, and that is something else to note. Whenever they do an upper or lower GI, they're always going to take pictures. Okay, so what was the findings? The findings is the esophagus appeared normal. There was no varices that they could see. And then the stomach, there was a large amount of solid food in the stomach. The procedure was aborted. So again, they could see the esophagus, that a clear view. Okay, and they didn't see any varices, and that's like a varicose vein. And so they were good. That was able to be a diagnostic test for them. But then when they get to the stomach, they couldn't see everything that they needed because there was substances in the stomach, and that means that they couldn't see the duodenum either, because there was something in the stomach. So they stopped the procedure. So now let's just walk through how they do this to get a better idea. So when they do an endoscopic procedure, they'll go in, if this is an upper GI, they'll go in through the mouth, and they give you some medication that you're not completely under, but you really have no idea what's going on, but they don't put you to sleep. And so then they just put the scope in, and they will look at the esophagus first with the camera. It's got a light on it. And then they go down into the stomach, and your stomach is truly shaped kind of like a kidney bean. Okay. And then right here in this graphic, you can see this is that pyloric sphincter that I was telling you about that opens and closes. And this is the duodenum, the beginning of the small intestine. Okay. So again, that's as far as they want to go for an EGD, because it's esophagus, gastro, which is stomach, and duodenum. Okay. Now, could they go farther? Yes, they could, but really, if they're going to start looking at the intestines themselves, what they do is they do a lower GI. And so they go up into the colon, and then go through the large intestine, and then on into the small intestine, and go that way. But for the most part, I don't really think they advance this scope much farther than the duodenum. Could they? Yeah, they could go a little bit farther, I guess. But one of the things that is going to help you is to know the entire digestive tract. And again, that starts, you got your mouth, which we're not, you have to know that's part of it. But the esophagus, the stomach, the duodenum, and then you need to know the portions of the small intestine, and then the large intestine, which is divided up into ascending and descending, and et cetera, et cetera. So we're not going to get into that because we're just doing this one report. Otherwise, we could go all the way through and talk about lower GIs, which also get stopped for various reasons. Okay, now, again, you can see if this was full of food, if you look at this little graphic, if there was food, they're not going to probably be able to see this. Keep in mind, gravity plays a part here. So you're not going to have a lot of food and residue in the top of the stomach, but it all pools down here at the bottom. And why would they be looking? Right, diagnostic varices. That tells me maybe they had blood. They were coughing up blood or had blood. They threw up blood. You want to see where's the bleeding coming from, and if you can't see the actual inner contents, then you can't see if there's an ulcer. Okay, now let's look at what this scope actually looks like. So this is a flexible tube, and at the very end of the flexible tube, there are components where the main thing is the light, because you want to visualize what you're looking at. So there's a little light at the end, and mind you, this is very tiny. Okay, so you got your little light source and a camera. Now the camera is to visualize what you're looking at, but it also takes pictures. Okay, and we want to have picture proof that everything is looking good, or that we see something abnormal. And I went ahead and grabbed some copies of pictures that they've taken of abnormalities so that you can get familiar with that. Notice here's an instrument port, because they can also do biopsies at this time, or maybe they want to run a snare through them and grab a polyp. And then notice this little dash right here, that's actually air. So sometimes they'll put a little air in there to puff it up just enough to then get a good view of what they want to see, or if there's any liquid in there, they kind of push out of the way. So actually several things can run through this little endoscopic flexible tube. Now, we're going to look at some of the different things you would see. And the first one that I grabbed, just so you know, this right here is the bottom of the stomach, right there by the pyloric sphincter. And then all of these little areas that look like folded fabric, or ruching, if you know what fabric is, that's where we're getting into the small intestine. So this is a view of the duodenum, the beginning of the small intestine. Okay, and it's telling you that in this particular one, we have a pigmented mass in the duodenal bulb, which is right where it opens up to the duodenum. Okay, so this is obviously it's attached. At first you think, oh, what, did they swallow something, you know, and it didn't pass or something. But no, this is actually tissue. And then it says they took more pictures of the duodenum, the second and third portion of the duodenum. So this is farther in. They don't want to just look at the sphincter and the opening of the duodenum. They're going to go into the second and third portions. So this is divided up. Here's obviously something right there, and here, second and third portion of the duodenum. Okay, and the gastric lining of your stomach is very smooth, slick, and so is the esophagus. It has kind of ridges, but it's nothing like this. This is what the inside of the intestines start to look like. So just visually, you can tell the difference, okay? And the fact that it's more red, maybe, but they didn't make a comment in that that is different, literally different tissue. This is gastric tissue, and this is intestinal tissue, small intestinal tissue. So the colors would be different, right? Now let's look at another one. For these slides, we've got endoscopic images, and we've got a gastric ulcer here at the first, and see these little white spots? They literally look like little cold sores, don't they? But this is gastric, this is stomach right here, okay? And it doesn't say where the gastric ulcer is, meaning, is this the top of the esophagus coming down, which I kind of think that it is. So you've got little ulcers at the top where the esophagus drops down into the stomach, and they've blown air in here so that we could see a little bit better. And again, they look like little cold sores. And you know what a cold sore or a sore inside your mouth feels like? That's exactly what you would feel. On this second one, notice it's gastritis. So it's not the little ulcers, but there's irritation and redness in here. So it is irritated. Then over here, we have esophagitis. Now, note, this is different looking than the inside of the stomach. This is an irritation. Esophagitis is inflammation, and this is the esophagus. And notice how it's shaped different, right? I'm assuming this is the opening into the stomach, right? And then right as you're going down through the esophagus, headed towards the stomach right here. Okay, and this is probably if this was the same patient, it's not. This is patient 4 and 6 and so on. So what you're seeing here is maybe like on this patient, you go into the esophagus, this is dropping down into the stomach. And I could be wrong. That could be the bulb before the duodenum as well. I don't know. And then D is a duodenal ulcer. Now, notice this blackness and the liquid here, and this ulcer is bleeding. You know, that's why you see that black. When a person who has an ulcer, a gastric ulcer, if they'll throw up, because whenever you get blood in your stomach, it makes you nauseous and you vomit. But the emesis, or what comes up, will look like coffee grounds. And notice how this kind of looks like coffee grounds right there. And it's blanched, it's white, it's irritated, right? But if a person has a bleed in the lower intestines, then the fecal matter, anything that comes out, is very black and tarry, which you would see that in the lining of the intestine, the lower intestine. Very good. Okay. So now we're going to talk about what this particular person found. So again, this was the question, and she said, is this just an endoscopic procedure, plain endoscopic procedure, or is it an EGD? Because they had planned to do an EGD, but they stopped because there was something in the stomach. So am I supposed to code it as an EGD, or do I code it as an endoscopic procedure? And then they kind of answered it themselves, because they went and found the CPT assistant, and even though it says December 13th, it doesn't matter, because unless something more, they change something and give you a more up-to-date one, this stands until it changes, and often it doesn't change. So on CPT assistants, that's very similar to Coding Clinic for ICD, and it always tells you how to find it. So this was the December 2013 edition. It literally tells you it's on page 3 through 7. It's a 19 category, and it stated, with an esophageal-gastroduodenoscopy overview, the following definition now applies to EGD examination services. So something changed in 2013. If you do an esophageal gastric where the duodenum is deliberately not examined, and they'll state judged clinically or not pertinent, okay? So in other words, they go in to do esophageal gastric, they don't care about the duodenum. It's not pertinent to what they want to look at. They just want to look at the stomach and the esophagus, okay? Or because the situation precludes such examination, meaning for some reason you can't see everything, and it would say like significant gastric retention, and that would mean there's food in the stomach. There's something in the stomach that's not allowing them to see. Okay, maybe you have blood in there and it's pooled and there's just liquid in there. You literally can't see what, if it's clear liquid, you can see, but again, you can't diagnose or treat what you can't see. So then they tell you, if this happens, then you're to append modifier 52. If a repeat examination is not planned. Okay, now let's stop right there. So they go in at the patient that we're looking at, the op that we just looked at. They didn't state whether they were going to go in and look again or not. Now, it could have been on the rest of the op, and she just didn't copy or paste that, but to give that to us. But they go in and they say, I didn't get to see everything that I wanted to see. We planned to do an EGD. We wanted to see the duodenum, but we couldn't because there was food still in the stomach. So we're not going to go look again. Okay, so you would code the EGD with modifier 52. That's what they're telling you, because it's the intent that you code. Just because you weren't able to fulfill the intent because there was food there, then it doesn't matter. What was the reason you were, there is a diagnostic code that is linked to this, and the diagnostic code was dysphagia, right, and looking for varices. So if you code this as not an EGD that was stopped, then statistics will not reveal the procedures that were done for these diagnoses. It will change the procedure protocol, right? So you have to think of it in the terms of, why am I doing this? Why am I coding this? For statistical purposes. Now, obviously the confusion was, but they didn't do it, so they shouldn't get paid for the EGD because they didn't actually do an EGD. They went in and they were able to see the esophagus and some of the stomach, but not all of the stomach. So what are we going to get paid for? And that's where the term intent comes in. What was the intent? Okay, the intent was to do a full EGD. We were stopped and weren't able to do the full view of the gastric because of gastric contents and of the stomach, and we weren't able to visualize the duodenum. So the intent was an EGD, we were stopped, so we append a modifier that tells the story. And if they're not going to do it again, go try to prep and not have any food in there, then you would use modifier 52. Now, if you are going to repeat the procedure, you can use modifier 53 if you plan to go in and do again. Now, this gets a little confusing because we're going to look at the two modifiers. So 52 is reduced services, and look at this line, the last line that I underlined. It says if we have a problem, you reduce the services because without disturbing the identification of the basic service. So in other words, we don't want to mess up the statistics. We wanted the intent to stand. We wanted to see a full EGD. So we can't disturb what the intention was, or it'll mess up the statistics. So we append modifier 52 because it was reduced, right? And they'll get paid less ultimately, because that's what modifier 52 says. But what about modifier 53? Oh, and I did add this because this is in there. Now, if you are coding for an ACS, which is a outpatient hospital outpatient facility coding, then you're going to use 73 or 74, which is kind of the same thing, but it's for ACS and hospitals. Okay, you won't use a 53 or 54. So just so you know that. So now let's look at 53. Discontinued procedure. Ultimately, it's telling you the same thing, except they terminated the surgical diagnostics procedure due to extenuating circumstances, which kind of sounds the same. Those that are life-threatening, the well-being of the patient, it may be necessary to indicate that a surgical or diagnostic procedure was started but discontinued. Okay, so they're very, very similar, but the circumstances here, you're going to report a 53 because you want to do it again, right? And oh, wait, I had more pictures, I thought. Hold on. I do. Sorry, let me go back. So again, let me go back to the op report. Well, first, this is what the coding clinic said. You're going to go ahead and do a 52. You're going to do the full intent, and this is relevant for doing a lower GI. This is actually pretty common. If there is a mass or a tumor in there and they start to go into the lower intestine and they can't get in, they can't go as far as they want to go and have to back out, then you're going to do the same thing. You have to code the intent. Okay, so I knew somebody that had this problem she'd been having for like 5 years, where she had problems going to the bathroom and pain and all this other stuff, and they kept telling her it was her nerves, it was this, it was that. Finally, it got so bad, they said, well, we'll go ahead and do a lower GI, and they weren't even able to get past the colon. They weren't able to get much farther past the rectum because there was a grapefruit size mass in there, and it was cancerous, so they backed out, right? And but you code the full intent, and they may have wanted to go all the way up through the large intestine into the small intestine to see what the problem is. They test for things like celiac disease a lot of times, where they'll do these procedures, and they'll take a little bit of tissue and a biopsy. Remember that little hole that you saw? And they'll go in and test for, my daughter was even tested for lactose intolerance and milk allergies, celiac disease, and several other things with a little bit of tissue directly from her EGD. And now she's going to go later and have another lower GI done, because she's had IBS since she was an infant. So again, note the difference between 52 and 53. Now, let me go back. I want to just clarify that. And I wanted to show you this adorable cartoon. And it says, please inform all your visitors that the videotape of your endoscopy is available in the gift shop. That's hilarious, isn't it? Because they literally do take pictures and give them to the patient if they so desire. I remember seeing pictures of my EGD that they did for me. I burnt a little place in my esophagus, but my stomach was in good shape. Okay, guys, any other questions that we might have? I know this was running a little short, about half the time, but one subject, intent. What's the intent? You always code the intent. And this is relevant both for purposes of the intestinal tract. It would be also relevant if we were doing anything via cardiac catheterization as well. What's the intent? How far are you going to go? If for some reason you aren't able to go any farther, then you code the intent, the pathway that you plan to go, and then use a modifier to give the reason why you were stopped, why we weren't able to continue. All right. Well, we'll keep it short and sweet this time then, and we'll see you next time. If you have any topics you want us to do, let us know. All right. Bye, guys.
And we're out.
That was short. I thought for sure, for some reason, I thought I had some more slides on there, but I guess that went faster than I thought. Oh, well.
It happens.
I don't mind the short ones. That's right. My beans are calling me.